Hello, parents and caregivers of children with cerebral palsy and those with lived experience. My name is Angela Harris, and I'm a member of the Community Council. I live just outside of Toronto, Canada. I'm a mom to a 17-year-old young woman with cerebral palsy. As she was born at 25 weeks, she was diagnosed with cerebral palsy at age 3. She was diagnosed with ataxia, dystonia, and spasticity. I also am a registered nurse who works at our local children's treatment center, and I work in our Botox clinic and our cerebral palsy clinic. Teaching about bone health has always been a passion of mine, but even more so after an accident with one of my daughter's sledge hockey teammates at the sledge hockey tournament. I would like to introduce you to our first speaker on the bone health session, Andrew and his mother Carrie, who would like to share their story.
Hi, my name is Andrew, and this is my mom, Carrie.
Hi.
I'm 17 years old. I'm in grade 12. I like reading, I play sledge hockey, and I play video games. I was born 8 weeks early, and the doctors discovered that I had a brain bleed that ultimately caused my cerebral palsy. When
Do you remember how old you were when you had your femur break?
when I was 15,
No, you were 12.
12.
That's okay.
12. When I was 12, I broke my femur at a sled hockey tournament. What had happened was both me and my mom were in a hotel room, and she had put me on like the bed to sit me up into a seating position, and she crossed my legs, and then there was I think my it popped first, and then there was like a big crack, and then I just felt like it felt good for about a couple seconds, and then it started hurting really bad. And then I had to go to a hospital in London for a surgery so that they could put it back into place, like pop it back into its socket. I
Yeah,
think.
and repair it, right? Remember, they had to put screws in and
Mm.
a plate and a big metal plate down the side of your left leg.
Mhm.
And that's what helped to, so that when the bone was healing, it would heal back into place, right? Yeah.
And that's when like we discovered that my bone density was a lot lower than normal, because I guess normally you wouldn't be able to like break it that easily
Mhm.
if you just like crossed your legs normally.
That's right.
So, and what I'm doing now, I have vitamin D, and
What else are you doing a lot of to try and keep your bones
I
strong?
I do a lot of like standing, and I do stretches every night
Mhm.
to help my bones like stay stronger.
Mhm.
But like the main thing is the vitamin D
Mhm.
that helps.
Mhm. And how important it is that you do it every day, right? To keep the bones strong and healthy, and so that they grow as well, because sometimes with cerebral palsy, your bones don't grow at the same rate as someone who doesn't have cerebral palsy. So it's important to do the stretching and the weight bearing and the vitamin D so that the bones can have every chance they can to grow, right? And grow strong.
Yeah.
Yeah. What was it like after you had the femur break and the surgery? What were things like after that? Do you remember the recovery?
I remember that I had to go home,
Mhm.
and I had to like, this was before COVID, so I had to like like get caught up on school like online, which back then was a little bit harder than it is now. because we didn't have like the virtual meetings, so I would just have to wait for work to like be posted online. And I was also in my bed and in my room for like the majority of the time.
It was about 3 to 4 weeks, right? That you weren't allowed to bear weight and you weren't allowed to do stretching because that was the time that your bones needed to heal and to get better. So at that point, the only thing you could do was to lay in bed and you could sit up in your bed, but that was all you were allowed to do, right? Until the bones healed more.
And then I remember like anytime that I needed to be transferred after that, it would need to be like a 2-person lift or a sling.
Because we had to keep your legs straight, right? We had to keep it straight out
Yeah.
so it didn't bend, right?
Mhm.
And
But
do you remember how long it took until you were fully healed?
no.
It was about, well, it happened in January, and May was when we got the final clearance that everything was good and you could go back to your regular activities. So about 5 months till you were fully healed.
But I think I went back to school like earlier.
You did. You did, yeah. You just weren't allowed to do your regular activities until the doctor said that everything was healed. And you had to go and have monthly appointments and x-rays done so they could check the bone and the healing, right? So you did that once a month.
I remember like a lot of people came to visit me.
Yeah, you did. You had a lot of visitors. Yeah. So why is it important to keep your bones strong and healthy?
So that like when you go to like stretch your like legs or bones in like a regular way, um it doesn't break as easily as mine. So it's important to like make sure that if you take vitamin D, you take vitamin D, and if you have stretches, you do them, because the more you do the stretches and the more you just help like your legs get stronger, the less likely it is that, or the more like the higher your bone density will be.
Exactly. Yeah. And as a parent, when it happened, it was very scary, but it was also very frightening and sad because literally all we were doing was bending his legs to go into a sitting position. And so when it snapped, we didn't believe that that's what had happened until we could feel the bulge in his leg and we knew that there was something wrong. And I remember thinking, what have I done? And the doctors were very reassuring and said that, kids with cerebral palsy, because of their bone density, it's, it is more likely that that type of thing can happen, and to not worry about it and not take it personally, because it could happen to anybody. So it just, I guess, it was a lesson learned to be very careful when you're doing positioning. And Andrew uses a wheelchair all of the time, and he does do his standing using a stander. And so just really important when you're doing movements and doing positioning that you're doing it really carefully, because it just doesn't take.
And slowly.
And slowly, that's right. Yeah, so that it's not resulting in that kind of a break, right? To the bone, yeah.
I remember, I think you did it fast too.
I was doing it pretty fast. I was, yeah. Is there anything else that's important to know?
I would also say just drink a lot of milk.
Drinking milk, yeah, for sure. Anything you can do to keep that bone density up, right? And you've done one bone density scan, and you'll do one now every couple of years, right? To get it checked.
Yeah.
And see how things are going. So it's important to also have your bone density checked so that you know exactly where it sits, right? Anything else you'd like to tell the audience?
No.
No,
No.
no, that you can injure yourself without being on the ice.
Yeah.
Right?
Yeah.
Yeah. So thank you.
So we heard from Andrew and his mother, Carrie, about a stress fracture that occurred during a transfer with his mother, both as a parent of a child with cerebral palsy and a nurse working in our local cerebral palsy clinic. Bone health has always been on my mind. I'd like to introduce you to Dr. Darcy Fehlings from Paul and Bloorview Kids Rehabilitation Hospital, just outside of Toronto, in Toronto, Canada. Dr. Fehlings is a developmental pediatrician who works with children with cerebral palsy and their families, and is the past president of the American Academy of Cerebral Palsy and Developmental Medicine, and has led a care pathway in osteoporosis and cerebral palsy. Dr. Fehlings?
Hi, everybody. I'm really pleased to be here to talk about bone health in children with cerebral palsy. And I thought I would ground my messaging by giving an outline of the care pathway that we have developed for bone health in children with cerebral palsy. And everyone can get to this through Dr. Google by just going AACPDM care pathway for osteoporosis. And it's an open site, and you'll be able to read, I think, some helpful information. So the way the site is organized, you'll see it on the screen here, is just go right to the section 1 evidence summary. And I'm going to walk you through it because it's got some important information. So first of all, you might be wondering, well, what is the definition of osteoporosis? And the important message that I want to tell you is that it consists of 2 things. One is the presence of low bone mineral density. So when you have a physical disability, you have low bone mineral density. However, just having low bone mineral density is not enough to meet the definition of osteoporosis. You also have to have a fragility fracture. And in children with cerebral palsy, these often occur in the long bones of the leg, for example, the femur. So why is osteoporosis important? We know that when we have a physical disability, such as cerebral palsy, you're at risk for fragility fractures because you have this low bone mineral density. But there's other things that can also impact on decreasing your bone health. So if your nutritional status is down, your weight maybe is low, and you're not getting enough calcium intake, that can also contribute to decreased bone health. And sometimes medications that we're on for other reasons. So for example, if you have a seizure disorder and you take some anticonvulsants, those medications can also lower the bone mineral density. We know that when we have decreased bone mineral density, if we have things like low speed trauma where we fall, we're at increased risk to have a fragility fracture. And of course, these can be painful. So when we look at trying to address promoting bone health, we have this color-coded algorithm here. And we've divided the treatment of osteoporosis into 2 arms. So this is really important to understand. So we have a prevention arm for children with cerebral palsy who are non-ambulatory, who will be at risk for osteoporosis, but they haven't had a fragility fracture yet. And then we also have a treatment arm for children who have had a fragility fracture. So let's talk about these 2 things separately. So if we're looking at the prevention arm, this is where we're really trying to promote, optimize our bone health. So what we've recommended is ensuring good calcium intake, ensuring that we're getting enough vitamin D and that we're promoting weight bearing. So let's talk about these a little bit more. So for calcium intake, you'll see here we have estimates for what is the recommended calcium that children should receive according to the age that they're at. And so what you want to do as a parent or a caregiver is ensure that your child is getting enough calcium in their diet. We recommend dietary calcium, like getting it through natural foods over a calcium supplement, because when we take calcium orally, it can constipate us. And we know that children with cerebral palsy are a little bit more at risk for constipation in and of itself. So we like to provide the calcium through a regular diet. And then for vitamin D, this is just the regular vitamin D that you can take. It's not a hydroxylated version. It's regular vitamin D, and this is very safe to take. And so we recommend taking between 800 to 1,000 international units. And this can be taken on a daily basis. The other thing that we're recommending is weight bearing. So we know when we're bearing weight through our bones, that helps to improve our bone mineral density. But if you have a physical disability, you don't bear weight through your bones as much. And so we have recommended a physiotherapy consult and exploring things like standing frames. And I know you're going to be hearing from a physiotherapist about that. So in the prevention arm, we don't recommend a lot of additional investigations. We have recommended a blood test to look at your vitamin D level. But we're not recommending any special x-rays or something called a DEXA scan if the child has not had a fragility fracture. And then you just monitor. And then if your child does go on to have a fragility fracture, then they are now meeting the diagnosis of osteoporosis, and they would move into the treatment arm. So here, in addition to continuing to make sure that the child's nutritional status is good and that they're getting enough calcium and vitamins, we're recommending consideration for a medication called bisphosphonates. And this medication is done under the guidance of a healthcare physician, and usually one that is a bone specialist. For children with cerebral palsy, we provide the bisphosphonates usually intravenously. Sometimes for older people who have osteoporosis, they're taking an oral medication, oral bisphosphonate, but there's some research to suggest that the intravenous treatment works slightly better for children with cerebral palsy. So in addition to the intervention with bisphosphonates, we are recommending a little bit more testing. So here we would do some blood work looking at the calcium. We would measure something called the parathyroid hormone, and again, measure the vitamin D levels. We would get x-rays of the area that's symptomatic, that's causing pain, to assess for the fracture. But also we would consider doing a spine x-ray to see if there's any evidence of vertebral compression fractures. And then finally, this is where we would recommend getting a formal measurement of the strength of the bone mineral density, using something called a DEXA scan. And that can also be used after you start to receive bisphosphonate to see if your bone mineral density is improving. So that, in a nutshell, is our general approach to osteoporosis management. And I'm just going to show you some other helpful aspects of the care pathway. So for those of you who like to review literature in more detail, these are the publications that we have published in developmental medicine, child neurology, and other journals that support the care pathway and what we're recommending. They're all active links, and you can just link into them and you'll get access to the full article. It can be a little bit of dense reading, though. We've really summarized it well in the evidence summary. And then the other aspect that I just wanted to show is the practical tools tab. And then you'll see that we've got some information that you might find helpful. So for example, you might be thinking, well, how can I ensure that my child's getting enough calcium in their diet? If you link into this particular handout, we've developed a sheet that gives you some information. So here's that age range and the amount of calcium that you should be getting. And then on the second page of this sheet, we've got some common foods that you're feeding your children and have given you information on the calcium content. We also have a guide for therapists who are developing weight-bearing programs, and just show some examples of the different types of standards that can be used. So I'm really pleased to provide an overview of our osteoporosis care pathway. And I know that Angela, who is a nurse in one of our children's treatment center, does a lot of osteoporosis prevention management and has some questions for me. So we'll transition to the question answer phase.
Thank you, Dr. Fehlings. So at what age should parents start to be concerned about their child's bone health?
You know, I wouldn't really say that there's a particular age cutoff. I think being aware that bone health can be an issue for children with cerebral palsy is important, particularly if your child is non-ambulatory. So we refer to that as gross motor function classification system 4 or 5. And often we start to establish the level of physical disability at the age of 2 years or over.
Excellent. And who could follow my child's bone health?
So if your child has not had a fragility fracture, then you can follow, but also your healthcare team can follow. Also the primary care provider that you may be seeing. So if you think back to the comments around the prevention arm, we want to make sure that we're monitoring nutritional status. So when you go to see a nurse or a physician, getting a weight and plotting that weight on the growth curves to see how your child's nutritional status is. And then also getting some counseling on making sure that your child is getting enough calcium, because that's important. And that's something that you can do now yourself by looking at that sheet. But often working with a nurse in the clinic is a great way to just ensure that your child's getting enough calcium. And then the other thing that the healthcare providers now recommending is that vitamin D supplementation, because it's just so safe to do. And getting something like D drops and looking at your child taking vitamin D on a regular basis, a daily basis, is a good idea. Now, if your child does have a fragility fracture, so some sort of stress fracture or low impact where if your bone health was good, you wouldn't necessarily have a fracture, then that moves your child into the treatment arm, where we're looking at considering adding the medication bisphosphonate. And that's often when you would get referred to a specialist that is very familiar with using bisphosphonates. And for example, in Toronto, it's our endocrinology team that provides the bisphosphonates for children with cerebral palsy who have fragility fractures. the other thing that you might be wondering is, well, if bisphosphonate works well to improve the bone strength, why aren't we using it in the prevention arm? And the reason that we have not recommended it in the prevention arm is that we don't have a lot of long-term information on the safety of using bisphosphonates in children's bones as they're growing. And so we know we have some evidence that bisphosphonate does improve bone mineral density, but because we don't have that complete reassurance that it's safe to use in a growing child, that's why we have it in the treatment arm. But there's some more recent evidence published out of our Scandinavian countries that children with cerebral palsy who are also on anticonvulsants like valproic acid or Depakine could consider also starting bisphosphonates even if they haven't had a fragility fracture. So that's something that we're considering updating the care pathway around in the near future.
Excellent. And I know in our clinic, we often talk with families that some people who have darker skin, and often we maybe suggest that they have increased levels of more vitamin D than we typically would suggest. Is that something that you talk to families about as well?
Absolutely. And the other thing is that if you're spending a lot of time inside and not getting exposure to the sun, then that also can decrease your vitamin D levels. So many children in Canada during the winter would fall into that category.
We often discuss that as well. Yes, our sun is quite limited here. How would I know if my child had a fracture? What could I look for?
Parents are really good at identifying if there's a problem. So the key is if you feel that something's wrong, the child will be in pain if they've had a fracture. And children with cerebral palsy, their sensation is really usually very good. So they will wince or complain of pain if they're able to communicate. But movement of the involved area will cause pain. There can sometimes be a little bit of swelling if you have a fracture of the distal femur, for example, with swelling and a little bit of redness. But the thing that parents will know the most is pain with any movement or touching of the area.
Excellent. Well, thank you so much for all your help today, Dr. Fehlings. I think families are really going to benefit. It's something I know I think both you and I feel very strongly about getting this information out regarding bone health. So thank you so much for your time.
Great. You're very welcome. Thank you.
Hi, everyone. My name is Casey O'Dwyer, and I'm a pediatric physiotherapist here today to talk to you about weight-bearing activities for children and youth pertaining to GMFCS level. I'm very excited to be here today as part of the Community Forum on Bone Health. So to start out, I wanted to sort of just summarize what the literature is saying today. And there are ongoing studies being completed because there is a lack of evidence-based recommendation for effective dosing of pediatric supported standing programs despite widespread clinical use. So in general, from pulling the literature, the standing programs that are implemented 5 days per week have been shown to positively affect bone mineral density, hip stability, range of motion at the hip, knee, and ankle, and as well as temporary reductions in muscle spasticity, which has been shown in some cases to help with comfort. So these are slightly different. You can see here, it's a little bit divided in terms of the duration of time that's spent in a standing or weight-bearing position per day. These are cumulative amounts. It's not 60 to 90 minutes at one time. It can be 30 minutes 3 times a day, for example. So you can just see the differences here a little bit, but generally the overall recommendation is regardless of our kiddos' functional abilities, if they're able to do weight bearing or supported standing in any means for 60 to 90 minutes a day, that's kind of the gold standard right now. So I decided to do my presentation just to categorize it a little bit. I've split up some different exercises and activities that you can consider based on the Gross Motor Functional Classification System, or the GMFCS for short. And what that is a 5-level classification system that describes the gross motor function of children in use with cerebral palsy on the basis of their self-initiated movement. There's particular emphasis on sitting, walking, and on wheeled mobility. So distinctions between the 5 different levels are based on functional ability, the need for assistive technology, including handheld mobility devices, whether that's a walker, a crutch, a cane, forearm crutches, as well as wheeled mobility. So whether that's a manual wheelchair, powered mobility in a powered wheelchair, all these things are considered to help determine the GMFCS level. So first we'll talk about clients or children who fall within the levels of GMFCS 1 to 2. So these typically are children who are on their feet and are able to walk short and long distances, both indoors and outdoors, but they may have some difficulty in regards to balance, coordination, strength. Sometimes walking on uneven surfaces, up, down hills, different terrain can be a bit more challenging. In some cases, for long distances, community mobility, we might be looking at wheeled mobility, so something like a manual wheelchair. So general ideas for this population of children, number 1 would be standing. So implementing any kind of balance activities, whether that is standing still, so static balance activities, standing and reaching, bending, squatting, whether that starts to implement dynamic activities, so including throwing a ball, catching a ball, kicking a ball, anything that has object manipulation. That also leads into where I've written here, weight shifting activities. So sometimes if we have someone with cerebral palsy who maybe has a diagnosis of hemiplegia, weight shifting activities is a great way to try and focus on shifting that weight over our more affected side in order to try and help with strengthening there and just that weight transfer over that affected side. For standing can also be transitions. So we would look at things like maybe can we practice some sit to stands, or maybe we practice moving from the floor, coming up into standing. All these things are implementing weight bearing and are good for our bone health. Secondly, to standing would be walking. So including community walks as much as possible, hikes on inclines or declines, walking or running games. So whether that can be games like Simon Says, red light, green light, you can modify that in certain ways, but really just keeping the kids up on their feet, walking as much as possible. Pending on our children's functional abilities, jumping and stair climbing are also functional ways that we are up on our feet. So whatever amount of assistance is required, if we're breaking down the skill of jumping, even just standing and working on bending our knees, coming down and then giving them that lift off with their hands. So they're getting a little bit of that nice impact through their joints, through their bones, because this impact and this weight bearing is how our bones actually become stronger and create new bone. And then finally, recreational activities, which is going to be a theme kind of throughout my part of the presentation. It's getting them involved in whatever interests them, whatever motivates them from a sports or active program perspective. And then you can see this beautiful photo here is bike riding. So bike riding is another way that even though we're not standing, even though we're not on our feet, by pushing into those pedals and having that resistive movement, that force that's being pushed into those pedals, that's actually sending force back up through your bones, and it's helping with the bone health and the strength within your legs. So your bone mineral density can certainly be targeted through an activity like bike riding, regardless of what kind of bike we're riding. So our next kids that we would talk about are those that might fall within a GMFCS 3. And these are typically children who would use some sort of mobility device to support ambulation or to support walking indoors and outdoors, whether that be this little friend here who's using a rear-facing walker, this orange one we've got, whether that be using crutches or canes. They might use something like that to support indoor mobility, shorter distance mobility. And then typically they might use like a manual wheelchair and use their arms to propel themselves for longer distances if walking with a walker or a different mobility device is just a bit tiring. So activities and ideas to consider in the GMFCS 3 population, again, there'll be a theme. So standing. So you might be working on standing balance with handheld assist or standing at the kitchen countertop, standing with our hands on the back of a chair, practicing those sit to stand movements. So you're getting some repetitions, but you're getting the break of sitting. We're just trying to look at ways of being on our feet as much as possible. And in the GMFCS3 population, you might consider use of a stander with your therapy team. So we've got a few more photos and a few different ideas as we get further into the presentation, but use of a stander might be something to consider at this point, because with a stander, we're able to get nice alignment. And the number one reason being, we can confirm that the weight is being distributed through our bones right in the direction that we want it to be. Secondary to standing, again, walking. So walking with whatever mobility aid they are able to use and works the best for them. Walking both indoors and outdoors, as well as this, of course, being great for kind of getting that total duration, at least that 60 to 90 minutes a day minimum that we're looking for our bone health, but it's also great on building endurance. So outside of standing and walking, because those can start to get a little bit challenging, as your GMFCS level, we're looking at GMFCS 3s or 4s, kneeling. Kneeling is another great way. It's not standing on our feet, but it's still absolutely targeting weight through the bones. So whether that's sustained high kneeling, moving from low kneeling up to high kneeling, which would just look like sitting back on your heels and then coming up, extending through your hips, squeezing your bum muscles and coming up and maintaining that high kneel position. And then if you can maintain that high kneel position, walking on your knees, forwards, backwards, side to side. These are great ways to still, you're sending weight up through your femurs, up through your hip joints. And you're still definitely targeting your bone health in that way. So sometimes that can be another activity that's implemented on top of the standing and the walking. And then recreational activities in this population of children, again, anything that's motivating for them, sports and active programs, any kind of adaptive bicycle, whatever sports they need to ride a bike. You can see in this great photo that we've got here, we're using an adaptive tricycle. And again, anytime our friend is pushing his legs, is moving through those pedal strokes, then we know that we're getting some impact on the bone health. So then for our GMFCS levels 4 and 5, these would be children who are primarily using wheeled mobility to support both indoor and outdoor mobility. A lot of the time that might look like powered mobility. They might use a more body weight supported walker or a gait trainer, we sometimes say, in order to support indoor walking and stepping. They certainly could use still some of these mobility devices, which are amazing in terms of allowing them to be up on their feet. So targeting that weight bearing piece, as well as navigating school, navigating outdoor environments, navigating even indoor environments if there's space. They are still able to use walkers that just have a few more accessories in order to achieve that same walking goal. So in this population, the standers and the walkers would be recommended to target the bone health and bone strengthening. So that would be use of a stander, whichever kind of stander might be recommended between yourself, your child, and your therapy team, ideally for 60 to 90 minutes a day. Use of a walker would be recommended, as we saw in the previous photo, for 20 to 30 minutes a day if possible. More is great if they can tolerate it, if they're not too tired and they're enjoying it, then absolutely. I actually wanted to bring up too, there has been some research lately that standing with hip abduction can be shown or has been shown to be positive in terms of helping with the hip joint and maintaining muscle length. So working with your therapy team to see if a stander that has the option of opening the legs a little bit more into hip abduction might be worth something to consider. There is new literature and research coming out on this. So stander and a walker can be great in all kinds of different environments. And we have a few great photos to show also to demonstrate that. Another way of targeting bone health, especially through our arms, is this awesome photo that we have here. So just working on a 4-point position or quadruped, putting weight through arms and legs, right? There's no reason that we always just have to think about standing and walking and that weight going through our legs. Absolutely any sort of weight bearing through our arms, whether it's in a 4-point position, a low kneel position where maybe some of the weight is back on our hips a bit, but we're still getting that weight through our arms, whether it's on our tummy and we're propping up through our arms. All of that is resistance coming from the floor, coming through our bones, and it's working on strengthening. And then following that, resistance activity. So if we have somebody who primarily uses a wheelchair, whether that be a power wheelchair or a manual wheelchair as their primary means of mobility, them going to the gym, whether it's a gym in the community, whether you have a home gym, whether it's a makeshift and it's not even with weights, it's just with any kind of somewhat heavier object you have at home, lifting those weights and any sort of resistance activity. So pushing up against gravity, anything like that is also great in terms of building the strength in your arms and building the strength of your upper extremity bones. And then finally, recreational activities, again, in this population, depending what their interests are, getting them involved in adaptive sports and games, learning about different sports or active programs that are available to them, and getting them involved early so they start to learn, you know, what's fun, what gets me active, gets me moving, but is also enjoyable, has that team format, would be really great. And again, adaptive bicycles. So the same thing across all GMFCS level, whatever kind of bike that you need to support your body, but you can then get that active pedaling through your legs. That's another great option. So finally, I just wanted to say that while the previous discussed activities do benefit our children in a variety of ways, there continues to be a need for research in the area of bone accrual and prevention and treatment options for osteoporosis in children with cerebral palsy. So we can see here, our friend is doing an awesome job by practicing that high kneeling. So that weight is going through his legs, and he's doing a great job here. And these are just some great photos that we have of different ways that we're implementing standing in different environments. So, you know, we're at the gym, we're working with a trainer, we're lifting, this is a double whammy. So we're lifting weights, we're working on the bone health of our upper body, and we're in a standing position. So we've got that weight through our lower legs, through our upper legs, through our hips. And then I love this one here. We're out cheering on the Jays, and we're getting that weight bearing at the same time, getting a good visual perspective, and having fun doing it. So thank you so much. And again, just please consult your child's physiotherapist regarding recommended mobility equipment, resistance, and weight bearing activities that would be appropriate for them based on their functional level.